Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 159 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, TLC, a 48-year-old female patient presents to your accident and emergency department with a chief complaint of sudden onset of left-sided weakness and facial droop, experienced malaise and a low-grade fever for several days. She has a past medical history significant for mitral valve prolapse, and mitral valve replacement 11 months ago. Her CT scan shows a left-sided ischemia with no evidence of hemorrhage. An echo is done and a 2 cm vegetation is seen on TLC's mitral valve. All 3 blood cultures obtained a growing Streptococcus galliticus, which has a penicillin MIC less than 0.06 mcg per milliliter and is susceptible to all other antibiotics tested. So my question to you is, which of the following best depicts the probability of an IE diagnosis, according to the modified Duke criteria? Is it A. insufficient evidence to classify, B. rejected diagnosis, C. probable diagnosis, or is it D. definite diagnosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. definite diagnosis. The patient has at least 2 major criteria: typical IE organism Streptococcus galliticus from at least 2 samples and a positive echocardiogram for IE. The patient also has several minor criteria: a predisposing heart condition, prosthetic mitral valve, and a thromboembolic complication. The patient's 2 major criteria alone would indicate definite IE. According to the modified Duke criteria, answer D is correct and answers A to C are incorrect. I will give you 10 seconds to choose the correct answer to this question from the listed options. So my question to you is, which of the regimens listed below would be the best therapy for TLC now? Would it be A. vancomycin for 42 days plus gentamicin for 14 days, or B. ceftriaxone for 42 days plus gentamicin for 14 days, C. vancomycin plus gentamicin for 14 days, or D. penicillin G plus gentamicin for 14 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. ceftriaxone for 42 days plus gentamicin for 14 days. Treatment selection for Streptococcus galliticus is partly based on the MIC of penicillin. Because the organism has a penicillin MIC less than 0.125 mcg per milliliter, it is considered highly penicillin susceptible. No history of penicillin intolerance is mentioned, and vancomycin would be inappropriate. That makes answers C and A incorrect. The patient also has a prosthetic mitral valve, which will require a longer course of therapy, making answer B correct and answer D incorrect. And the next question reads, before presentation to your accident and emergency department, TLC was taking warfarin. Warfarin was held on admission, and 3 days later, the team is now considering reinitiating it. So my question to you is, which of the following would be the most appropriate recommendation for management at this time with regard to thromboprophylaxis? Would it be A. Reinitiate warfarin and bridge with low molecular weight heparin until her international normalized ratio is therapeutic, or B. Discontinue warfarin and initiate unfractionated heparin, or C. Continue to hold warfarin for at least 14 days, or would it be D. Reinitiate warfarin, assuming the patient is stable? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Continue to hold warfarin for at least 14 days. Anticoagulation use in the treatment of infective endocarditis has no clinical benefit. Anticoagulation use in a patient with IE who also presents with a CNS embolic event could place the patient at risk of developing a hemorrhagic event. That makes answers D, B, and A incorrect. Because of this risk, anticoagulant therapy should be held for at least 2 weeks. That makes answer C correct. Please advance to the next slide. And the next question reads, TLC completes a full course of antibiotic therapy with no further events. 7 months later, TLC must have a tooth removed secondary to dental caries. So my question to you is, which of the following would be the most appropriate to recommend regarding antimicrobial prophylaxis to prevent recurrent infective endocarditis? Would it be A. Give penicillin VK 500 mg tablet, dosed at 1 tablet by mouth 60 minutes before procedure and every 6 hours for 4 doses, or B. Give cephalexin 500 mg capsule, dosed at 4 capsules by mouth 30 minutes before procedure, or C. Give amoxicillin 500 mg capsule, dosed at 1 capsule by mouth 60 minutes before procedure, or would it be D. No antibiotic prophylaxis is necessary? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Give cephalexin 500 mg capsule, dosed at 4 capsules by mouth 30 minutes before procedure. Antimicrobial prophylaxis should be considered for groups at high risk of infective endocarditis undergoing invasive dental procedures. This patient is a high-risk candidate for 2 reasons: 1. The presence of a prosthetic valve, and 2. A history of infective endocarditis. Because a dental abstraction would be considered invasive, answer D would not be best for this patient. Dosing for dental prophylaxis should be a single dose given 30 to 60 minutes before the procedure is begun, making answers C and A incorrect and answer B correct. Please advance to the next question. And the next question reads, PCB, a 65-year-old female patient presents to your accident and emergency department with a 7-day history of increasing fatigue and, over the past 2 days, she has noticed erythema and pain over the site of implantation. She has a past medical history significant for inducible ventricular fibrillation and ICD placement 4 years ago. On presentation, PCB is initiated on vancomycin and cefepime. Her pertinent labs include a WBC of 16.6 times 10^3 cells per millimeter cubed. Her pertinent vitals include a blood pressure of 102 systolic, and 64 diastolic, a heart rate of 104 beats per minute, a body temperature of 39.2 degrees Celsius, a respiratory rate of 24 breaths per minute, and her oxygen saturation is 96% on 2 liters of oxygen. 2 blood cultures reveal MRSA. A TEE identifies a 2.5 cm vegetation on the tricuspid valve and a 1 cm vegetation on the right device lead. The patient is scheduled for device removal in 48 hours. So my question to you is, which of the following would be the most appropriate recommendation for PCB's antibiotic therapy at this time? Would it be A. Continue vancomycin, or B. Change vancomycin to ceftaroline, or C. Add gentamicin and rifampin, or would it be D. Add gentamicin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Add gentamicin and rifampin. Patients with a cardiac device infection and vegetation on the heart valve should be treated according to infective endocarditis treatment guidelines. Although surgery is scheduled in 2 days, surgical removal is often more difficult in patients with long-standing devices because of the presence of scar tissue. Antibiotic therapy should be based on Staphylococcus aureus infection in the presence of prosthetic material, and both gentamicin and rifampin should be added to vancomycin. That makes answer C correct and answers A, B, and D incorrect. Once the device is removed and replaced, both gentamicin and rifampin should be evaluated for continuation. Please advance to the next slide. And the next question reads, GTF, is a 33-year-old male patient who presents to your hospital with a 3-day history of unremitting substernal chest pain that radiates to his shoulders, which worsens when he is lying down at rest. He denies any dyspnea. His pertinent labs include the fact that cardiac enzyme levels is within normal limits except for a WBC 18.2 times 10^3 cells per millimeter cubed, a CRP of 12.8 mg per deciliter. His pertinent vitals include a blood pressure of 126 systolic and 82 diastolic, a heart rate of 78 beats per minute, a respiratory rate of 18 breaths per minute, and a body temperature of 37.7 degrees Celsius. An ECG is done and it reveals PR segment depression. An echo is done and turns out positive for a moderate-size pericardial effusion without hemodynamic compromise. 2 sets of blood cultures have no growth at 24 hours, and viral serology is negative. A diagnosis of acute pericarditis is made and he is scheduled for a pericardiocentesis later today. So my question to you is, which of the following would be the most appropriate to initiate in GTF's case at this time? Is it A. cefepime plus vancomycin plus acyclovir, or B. cefepime plus vancomycin, or C. acyclovir, or is it D. ibuprofen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, ibuprofen. At this time, the patient's acute pericarditis would be classified as idiopathic. Anti-inflammatory medications are recommended to control inflammation in this case. That makes answer D correct. Information is lacking to support the use of an antiviral agent such as acyclovir. That makes answers C and A incorrect. Some acute pericarditis may be caused by bacteria, which should be suspected in cases with purulent disease. In these cases, it is helpful to wait until pericardiocentesis is performed. If purulent fluid is identified, empiric antibiotic therapy should be directed at gram-negative and gram-positive organisms. Because there is no evidence of purulent disease, answer B would be incorrect at this time. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 160.